Excellence, led by Professor Faye Johnson out of the Menzies Institute for Medical Research here at the University of Tasmania. It's a network of researchers, academics, and supporters that really have the mission of advocating for a healthier community through safe air, underpinned by evidence-based policy and practice. And there's really several threads to the way that the centre operates. It's focused on translating evidence-based information into policy and practice, training the next generation of researchers, and also generating the data and synthesising the data that's out there to support those two things. And in the spirit of that, the session today is really just a high-level overview of some of the potential health impacts of air pollution beyond the hearts and lungs. And we're also supporting a number of individuals at various stages of their careers. So some people are just starting out in their PhDs. Some people, and perhaps I'm in that category, have been doing this for many years. So really, I would ask everyone to be supportive of those who are presenting today. So I'll just start with an acknowledgement of country, and I pay my respects to elders past and present. The community that we're meeting, that is represented, we're meeting on their lands today, is the Palawa Pakana people of Lutruwita. I pay my respects to their elders past and present. Also recognise the old people who are the holders of the knowledge over several thousand years, and recognise that this is and always will be Aboriginal land. I'd also like to reflect on the acknowledgement today, given that we're talking about air pollution, that many Indigenous populations are over-affected, or I'm trying to think of the right words, are particularly susceptible to the effects of air pollution because of their circumstances, and often in circumstances out of their control, but also recognise that there are Indigenous knowledges and Indigenous knowledge systems that might contribute to how we mitigate against the effects of air pollution. So my job here today is really just to give you an introduction to this session and give you a quick overview. I should point out that this session is broken up sort of into three parts. We'll have 3 10-minute talks. We'll be trying to keep to time as best we can. And at the end of those 3 talks, we'll have a time for discussion about the particular topic that we'll be speaking about. There'll also be short breaks between each of the 3 sessions, so you'll have a chance to get up and move around. So my job here today is really to talk about the potential mechanisms that might be driving the broad health effects of air pollution. And we're not talking about cardiovascular disease or respiratory disease today, but we know that air pollution causes the development of diseases in these systems and also exacerbates diseases of these systems. And I wrote an opinion piece sometime last year, kind of highlighting the fact that we really don't need any more evidence to support the link between air pollution and these particular organ systems and the health effects. And really, we should be focusing our research efforts in other areas rather than just describing the problem, thinking about what the solutions are. But there are a whole range of other potential health effects of air pollution where the evidence is on the spectrum from emerging to potentially solid ground, and that's what we're going to hear about today. And so we're going to hear about hear from a series of presenters today covering a range of topics. For example, the effects of air pollution potentially on development in early life, maternal health, metabolic disease, brain health, cancer, and perhaps some ones that people often don't think about, bone health and eye health. And so I'm really interested to hear what the speakers have, the experts in these particular fields have to talk to us about today. And so to sort of set the scene, what I wanted to do is give a sort of high-level overview of why air pollution might potentially affect all of the organ systems in the body and have an impact on all of these diseases and biological processes. And if we just take one component of air pollution for now, so let's just think about particles. It's really important to think about what happens to a particle when you inhale it. Of course, we're going to hear about eye health, which doesn't require the inhalation of particles. But if we just think about the respiratory system for the moment and what happens to a particle when you inhale it, this is a slightly technical diagram, which is really just a representation of the lung and the airways. And so here, for those of you, wrong button, for those of you in the room, we have an airway here, and here we have the end of the airway, which is the alveoli, where all the gas exchange happens. And so what you can see is that there's a whole range of different cell types that line the airway and the gas exchanging spaces. And so it's possible for a particle to come into contact with all of these different cell types, and all of these different cell types can react in a different way when they come into contact with those particles. So if you inhale particles, there's a number of different fates for those particles. The sort of primary line of defense for the system is the mucociliary escalator. So the particles come into contact with the liquid that's lining the airway surface. It captures those particles, and through the coordinated beating of the cilia that sit on these ciliated epithelial cells, it moves the particles back up and out of the lungs, where you either expectorate them i.e. you cough them up or you swallow them. And it's really interesting to think about what happens when you swallow those particles and the potential health effects, but we're not really covering that today. It's also possible for those particles to enter cells. So there are cells that line the airways called epithelial cells. We know that particles can enter those cells. There are sentinel cells that line the gas exchange spaces called macrophages. Those are part of the innate immune system, and it's their job to identify, recognize, and respond to foreign bodies. So macrophages readily engulf all types of particles and potentially respond to them. It's also possible for those particles to actually exit the respiratory system by penetrating the tissue lining the respiratory system. And from there, it can enter the circulation. Oh. I'm throwing my voice. That's all right. I'll just dance thinking about particles. Oh, thank you. Thank you. Oh, here we go. We're good to go. All right. So we've got particles coming in, hopefully going up the mucociliary escalator, potentially going into cells, potentially penetrating the interstitium where they can enter the circulation and potentially have systemic effects. And we also know that the particles can then enter the lymph system, and it's through the lymph system that they can come into contact with the adaptive immune system and cause long-term immune effects. And so one of the questions you might ask is, okay, well, the particles enter the respiratory system, they're trafficked to a whole range of different places. How do the cells respond? And the cells can respond in a whole series of different ways. If a particle comes into contact with the cell and that particle contains compounds that are directly toxic, it can kill the cells. So one potential response is that the cell can die or have some sort of dysfunction as a result of the chemicals in that particle. One of the common responses to particles is through oxidative stress. Oxidative stress is really just the balance between certain chemicals in a biological system that indicate whether something is going awry or not. And so oxidative stress can be driven either by the cell responding to the particle or also by the chemicals that the particles release. So for example, we know that if you inhale a particle and iron is released from that particle, it will influence the oxidative balance and therefore cause oxidative stress. And through those processes, what you often get is an inflammatory response or immune modulation. Now, it's important to point out that these responses from the biological system, from the cells, are actually unnecessary. And what's happening is the particles are triggering innate responses that are sort of built into the cellular system that are essentially there to recognize foreign bodies that are threats, in other words, pathogens. So many of the cellular receptors that are there to recognize bacteria and viruses are also triggered by particles. So the problem is that the particle, which in and of itself might be relatively inert, a good example is silica. Silica as a molecule is actually really chemically stable, doesn't really have a chemical activity. But if that silica particle comes into contact with a cell, it recognizes it a threat and produces an inflammatory response. And you can also have long-term effects if it modulates the expression of certain genes through permanent mutagenic effects. And this is just a diagram on the right showing a cellular response to a particle, for a lung cell from some of the work that we've done. And of course, then you have to think about what's the outcome. And there are sort of two broad categories of outcome. One is through these effects, you can get tissue injury. So it causes scarring, remodeling, tissue destruction. And as a result, that organ system may no longer perform the function that's required. And something that's probably often not thought about so much is the impaired response to secondary insults. So if you have inflammation, immune modulation, oxidative stress, what that can do is impair the system from responding to other insults. Here's an example of some data that some studies that we did showing that if you put an inorganic particle on a cell, it enhances the ability of a bacteria to invade that cell. And so as a result of the potential wide range of fates for particles, they can affect all parts of the body. We also know because of all the potential responses from the cells, they can have a wide range of potential health effects. And I'm just conscious of the time. So what I'm going to do is I'm going to just talk about this one and then skip to the overview. So one of the things that I think we need to think about when we're thinking about what the the effect of exposure to air pollution is on an individual is it's a complex interaction between a whole range of things. Firstly, it's impacted by the pollutant composition. Are we talking about a gas? Are we talking about a particle? Are we talking about a particle of a particular size, which will dictate where the particle goes and how the cells respond? What's the chemistry of the particle? Because the chemistry will also affect the way that the cell responds. Are we talking about an acute exposure event, a chronic exposure event, a complex mix of acute on chronic? So this is Saharan dust over London, where you have a complex mix of inorganic particles from the desert versus air pollution from largely from combustion sources. And then who are we talking about? Are we talking about someone who's otherwise healthy? Are they young? Are they older? Do they have an existing chronic disease? Some examples here from the respiratory system. Do they have an acute disease? Do they have a respiratory infection, for example? And the interaction between all of those things will dictate what the response is for an individual. As I said, I'll just skip over these next two because they're probably not particularly important. I think they're important, but I've just run out of time. As an overview, inhaled particles are widely distributed throughout the body. And of course, I haven't mentioned gases at all today. And of course, gases like nitrogen dioxide, for example, can also enter the body, be distributed through a range of places throughout the body, and also cause a range of cellular responses. There are also other routes of exposure, as I mentioned before, so I focused on the respiratory system. We also have some talks today about in utero exposure. So we know, for example, that particles can directly cross the placenta. We also know that some of the potential in utero effects are driven by the fact that the maternal system responds to exposure to the particles, and that therefore changes the environment for the developing fetus. And clearly, the potential health effects as a result are well beyond the heart and the lung. The response depends on the physical and chemical characteristics of the pollution, which I've mentioned, and is also, as a result, is also driven by a complex interaction between dose and a range of other host factors. So thank you for listening to that very whirlwind introduction. Hopefully it sets the scene for the conversation that we're coming up. I'd now like to welcome Professor Camille Rains-Greenough, who is online, I believe, who is going to talk to us about perinatal and neonatal outcomes as a result of exposure to air pollution.
Great, thanks very much, and thanks for having me. And that was a great introduction, and I'm glad that I dropped a couple of my slides in the interest of time because they fit perfectly with the, you've covered everything that I wanted to cover, particularly the complex issues around what are we trying to actually unpack. So before I begin, I just want to acknowledge that I'm on Gadigal land, and I want to pay my respects as well to the people from my region here. And today I'm specifically speaking about perinatal and child health outcomes related to wildfire exposure. And this was from a book, this was based on work that we did for a multidisciplinary book called Fire, Smoke and Health, Tracking the Modelling Chain from Flames to Health and Wellbeing. And the aim of this chapter is to provide an overview of the associations between wildfire smoke and perinatal and child health outcomes. And we had originally planned to conduct a systematic review with a meta-analysis of the existing literature. However, there was just the evidence was so insufficient and was too heterogeneous to compare. And so basically, this is what I'm presenting today. I do have a couple of disclaimers that we haven't updated the review. And I know that there's been some new research published, including the 23 publication using data from New South Wales Health, which was probably one of the biggest ones. Sorry, got too many things. There we go. So just to give you a bit of a brief outline, I'm going to give you a brief background, then discuss some of the specific issues around the vulnerabilities of pregnancy and childhood, discuss the methodological issues, provide an overview of the effects, and then conclude with some of the research gaps and ideas for future directions, which are wide open if you're looking for a new research area. So as you know, air pollution from wild or bushfire events, I'll use those words interchangeably, pose enormous threats to human health, but there's really limited literature on wildfire and smoke exposure during pregnancy and childhood. There's much more research, as you well know, on ambient air pollution and in particular respiratory outcomes in this area. But pregnancy is a very important and complicated time and has unique characteristics that need research. So pregnancy, just to give you a brief reminder, is divided into the 3 trimesters and then further into 40 weeks. And here are some of the morbidity and mortality outcomes that we're really interested in this field. And what's interesting is that pregnancy is time dependent and also is really inconsistent. So an exposure that occurs in one gestational window may not cause harm to the developing fetus or to the woman, whereas if it occurred in another or a different gestational window, it may be fatal or cause harm, and that is evident. It could be evident at birth or soon after, or it may be related to adult disease. And there are so many physiological changes that occur to the pregnant woman through pregnancy, making it a more vulnerable, and it's also a time of rapid growth and development for the fetus, also making it a vulnerable time. So the pregnancy vulnerability is related to all the immense physiological changes that involve all organ systems, and these lead to the increased vulnerability. There's also increases in respiration, oxygen consumption, cardiac output, and there's also some hematological changes that are increased, that put the woman at increased risk of anemia. And there's evidence that air pollution is associated with anemia and further compounding the risk. The immune system also adapts to having a foreign body in the woman, and air pollution disrupts the immune system. The fetal vulnerability is related to the gestational period, and it's, like I said, it's a rapid time of rapid growth and development. And although the placenta is amazing as a primary barrier of toxins, PM2.5 has been shown to cross the barrier, as already has been mentioned. And there's also recent evidence that black carbon accumulates on the fetal side of the placenta as well. And any impaired placental function is linked to common pregnancy complications such as low birth weight and diseases in adulthood as well. I'm racing through all this just to keep up with time. So childhood also is a recognised window of vulnerability due to the immature immune system. So children's developmental stage and their behaviour makes them at risk. So things such as they're less likely to adopt risk mitigation behaviours, have less access to appropriately sized masks, for example, or that they may spend more time in places where they have insufficient air ventilation, such as at school. And young children, smaller airways, smaller lung sizes, high respiratory rates, increased metabolic rates, increases their exposure and vulnerability to respirable pollution. The impact on adult health after exposure in childhood is also unknown. There are animal models of early life exposure and longer-term morbidity are suggestive of immune dysregulation and changes to lung function that extend at least into adolescence. But again, it's a wide open area for investigation. So for the work that we did, this is all on epidemiological evidence mostly. And the body of work covers about 10 years or so, and that they've employed the epidemiological evidence studies have employed a range of different study designs, including retrospective cohorts, case control, case crossover, time series, and ecological study designs. The exposure assessment was extremely heterogeneous, and primarily based on ecological exposure to a single fire event or increases in PM2.5 during periods of wildfire events. The studies included a mix of distal and proximal assessment of fire exposure, such as using residential or school address, or self-report of indoor smoke smell, which, as you can imagine, is not a very good indicator necessarily of exposure. These studies have been conducted all over the world, from wildfires in Western US and Canada, Indonesia, South America, and Australia. And there's also a landscape fire study using data from low and middle income countries. Now, the main outcomes are listed here on the page. Birth weight was one of the frequently studied outcomes, and there was a decrease overall in birth weight, which is a major indicator of the health of the fetus, except in one study and in boys from California. Preterm birth was shown to increase, which is also a major complication and a major morbidity for infants. And that was increased from 4 studies: Australia, Brazil, Colorado, and California. Congenital anomalies, didn't seem to be any change in the presence of congenital anomalies, but that was just from one study. There was gastroschisis, which was an increase, which is a type of congenital anomaly. There was an increase in that. Infant mortality was based on a modelling study from Indonesia, and it was suspected to increase. There was a pregnancy loss study, but that was in macaques, and it was shown to increase. It wasn't the best study as far as epidemiological evidence goes. And there was another study looking at peritraumatic distress from Canada, and it was determined to be a likely impact. Of course, stress is a component of a risk factor for pregnancy outcomes, poor pregnancy outcomes as well. The childhood outcomes, there was even less research conducted in children, and mostly from high income settings and just mostly from the US, Australia, and Europe. And they focused on acute outcomes, mostly again, respiratory outcomes or disease and medication use and health service use. The acute outcomes listed there. You can see doctor visits, there was an increase. There was 3 studies from California and 1 from Washington. Asthma hospitalizations, increase. There was 1 study from Sydney, which showing that was decrease. Cough, wheeze, respiratory symptoms increase. Lots of studies on that. Asthma medication increase. Pulmonary function decrease. Anxiety and depression, 1 study from Greece, which was shown to increase, and that was in adolescents. Academic achievement was shown to decrease. That was from a nice study from Victoria. School attendance, which was just a byproduct of school lockdowns, was shown to decrease in California from 2 studies. Physical activity, which was based on a randomized control trial, which was really interesting, had no change until the smoke exposure was really extreme, and then the children were asked to come and play inside. Under 5 mortality increase, breastfeeding decrease, but that was again probably related to social factors. Sorry, getting my tongue tied there. So in summary, wildfire smoke during pregnancy was related to low birth weight, higher rates of preterm birth, birth defects, infant mortality and pregnancy loss still unknown and wide open field. Wildfire smoke during childhood, high respiratory disease, more symptoms, more hospitalizations and doctor visits. The research gaps and future directions are wide open, as I've already said. We need some prospective longitudinal studies, assess levels of exposure. Graham put up a really great slide looking at the different mix of exposure, and throw in pregnancy there and the stress of exposure to a fire event, and you really got a really amazing mix of different exposures that cause poor pregnancy outcomes. We need some studies looking at the life course outcomes as well. What happens if you have an exposure in childhood or during gestation? What happens to your adult disease, risk of disease? We need studies from other settings and countries as well that have other complex mix of different exposures. We absolutely need to identify the critical windows of exposure, of which gestational window is most critical for different outcomes. We need to better understand the biological mechanisms for pregnancy. The psychosocial effects also need to be understood, the vulnerable populations and communities as I've hinted at. And there's additional maternal and infant child health outcomes that need to be investigated, and in assessment of interventions and mitigation as well. There's really no evidence on that for children at this stage, and these will be personal or policy. And thank you for everyone out there who's done all the hard work. I've probably covered your paper. That's it for now. Thank you.
Good morning. So I'll be focusing specifically on air pollution and gestational diabetes as a selected pregnancy complication. I'd like to start by acknowledging the traditional custodians and owners of the land and waters of this island, Lutruwita. I'd like to pay my respects to the Tasmanian Aboriginal communities, as well as elders past, present and emerging. So I will keep the background quite brief because there's been an excellent context provided by both Graham and Camille, so thank you for that. But just to frame that we know that air pollution is the single greatest environmental threat to human health and well-being, with substantial morbidity and mortality experienced each year. And we're looking today beyond the heart and lung health harms. Within the Australian context, it is important for us to characterise why the health harms of air pollution are particularly important for us to understand. We know that we experience relatively good air quality in Australia, but these episodic periods of poor air quality are not uncommon, as recently demonstrated in the extreme during the 2019 Black Summer fires. We are expecting that bushfire activity will increase with a changing climate, with severe smoke events likely to increase in frequency and severity. And we know, as Camille has described and provided excellent context for this next part of my talk, that the in utero exposures in particular are quite critical because they can have a profound effect on one's risk for development of future adult disease. So characterising the harms of air pollution in pregnancy is particularly important and not particularly well understood. In 2019, we did attempt to synthesise the evidence by conducting a systematic review looking at maternal exposure to short to medium term outdoor air pollution events and selected obstetric and neonatal outcomes. We found a small number of studies, as Camille highlighted. We found 11 studies that were eventually included in the systematic review. They were highly heterogeneous and really difficult to synthesize given the varying methodology around how assessment was how exposure was assessed, which windows of exposure were assessed, how outcomes were defined, the various confounders that were controlled for or not, and how to generalize findings in international studies into the Australian context. And certainly the evidence base is stronger looking at ambient air pollution and obstetric and neonatal outcomes over severe smoke events, as well as stronger for neonatal outcomes such as low birth weight and preterm birth over those obstetric outcomes. These knowledge gaps were highlighted during the 2014 Hazelwood coal mine fire, which I'm sure many in the room are familiar with. This was an unprecedented event that resulted in a 6-week period of poor air quality in the Latrobe Valley region in regional Victoria. This event resulted in surrounding towns being blanketed in smoke and ash, substantial community concern at the time, and the air quality standards were exceeded for fine particulate matter for 23 days in the town of Morwell, 5 days in Traralgon, 3 days in Churchill, and 2 days in Moe. At the time, there was substantial community concern, and it's fair to say that the public health response was hindered by the lack of evidence concerning the potential health harms of a smoke event of that duration that sort of sits in that short to medium term period. And so born out of this event was the Hazelwood Health Study, which aimed to understand the health harms associated with that specific severe smoke event. And one of the streams that Faye leads is the Latrobe Early Life Follow-up Study, or the ELF study, which specifically looks at exposure to pregnant women and young children and aims to characterise those health harms. So I'm going to focus now on a particular study within the Latrobe ELF study, which is part of my PhD, and the punchline's really here, so I'm giving away the key finding. But we used the Latrobe ELF study through a prospective cohort to look at maternal exposure to fine particulate matter to the Hazelwood coal mine fire and found that it was associated with gestational diabetes. So our aims through this study was to look at fine particulate matter exposure to women who were pregnant during the event and whether it was associated with selected pregnancy complications. So we looked specifically at gestational diabetes, hypertensive disorders of pregnancy, and abnormal placentation. And we looked at these because there was some literature that suggesting that there could be a link with air pollution. So we wanted to tease this out specifically. We did this by defining a cohort of pregnant women with births over 20 weeks in the Latrobe Valley from 1 March 2012 to 31 December 2015. So this was a cohort of women who were pregnant before, during, and after the fire. We included singleton births, and we used an administrative data set, the Victorian Perinatal Data Collection. We defined our outcomes of interest using ICD-10 codes, looking at gestational diabetes, hypertensive disorders of pregnancy, which collectively includes pregnancy-induced hypertension, preeclampsia, and eclampsia, as well as conditions characterised by abnormal placentation, such as placenta previa, placenta accreta, and abruption. Really important to note that we only had fact of diagnosis in pregnancy. We didn't have information about when that diagnosis occurred within the pregnancy. For our exposure, we assigned an average and a peak fine particulate matter associated with the coal mine fire, assigned to the residential address at delivery at the SA1 level to each pregnancy. And we did this using a chemical transport model that our collaborators at CSIRO had developed, which estimated PM2.5 attributable to that coal mine fire at an hourly time step and at a 1 by 1 kilometre spatial resolution. We accounted for a range of maternal, meteorological, and temporal variables in our final log binomial regression models. And so what we found looking at our results was that we had a total cohort of 3,612 singleton pregnancies, and just over a fifth of those were pregnant during the coal mine fire event, so 21%. So this was our exposed cohort. The median maternal age was 28 years, which is younger than the general Victorian population. And looking at those pregnancy conditions of interest, just over 6% had GDM. This is slightly below the Victorian population average and we think relates to the younger age of the maternal cohort. Just under 5% had a pregnancy-related hypertensive disorder, and just under 1% had a condition of abnormal placentation. In terms of their exposure, the median daily average PM2.5 was 1.9 micrograms per cubic metre, and the median peak, so their highest exposure during that 6-week period, was 30.2. Putting that exposure and presenting it graphically, we've got average on the left and peak on the right. So you can see that the peak exposures were a bit more variable. You can see more spread in the observations, and the average exposures were more tightly clustered together. And I think whilst this was a severe smoke event in the Australian context, it's also important to note that these air quality levels are similar or even lower at times than what our global neighbours are exposed to through ambient air pollution. So we did not find an association between PM2.5 exposure in pregnancy and hypertensive disorders of pregnancy or abnormal placentation. However, we did find a strong relationship between maternal exposure to PM2.5 from the coal mine fire event and gestational diabetes. So for average PM2.5, for each interquartile range increase in exposure, there was a 6% increased risk of gestational diabetes. And for an interquartile range increase in peak exposure, so their highest exposure in that time, there was a 15% increased risk of gestational diabetes. Framing this as an attributable risk, there were additional 16 cases of GDM directly attributable to the fire smoke event. The confounders that we adjusted for are listed there in the footnote as well. The relationship between maternal exposure and outcome was strongest for the second trimester. And as I mentioned in the methods, we weren't able to tease out when GDM was diagnosed in pregnancy. And so we were trying to make sure we weren't overestimating this association and simply counting prevalent cases that were already there regardless of the smoke event. And so we did a sensitivity analysis to look specifically at the subset of those who were in their first 24 weeks of pregnancy at the start of the fire. For most women, gestational diabetes is diagnosed somewhere between 24 to 28 weeks based on the timing of screening. And we found that through this subset analysis, the association was preserved, which gave us more confidence that the association was likely real. And at the time, and to our knowledge, this was the first study that looked specifically at the relationship between maternal exposure to air pollution from a severe smoke event and gestational diabetes. We thought that this is likely to be of clinical and public health significance because we know gestational diabetes is associated with short, medium and long-term morbidity for mum and baby. However, recognise that certainly a lot that further research was certainly required to corroborate our findings and to unpack this further. Important to note our limitation. So I've already mentioned the timing of diagnosis. We weren't able to account for maternal mobility in pregnancy, which is possibly important given that it was an emergency event and that people may have moved. We weren't able to account for some potentially important covariants like maternal BMI. However, our covariate list was fairly comprehensive, but we did recognise this particular gap. And there was a change in diagnostic criteria for GDM during the study period such that the threshold was lowered for diagnosis. And we tried to account for this by accounting for year of conception year of conception in the analysis. So in the few studies concerning gestational diabetes mellitus, or GDM, findings suggest an association, but are mixed in relation to the relative importance of different pollutants, the timing of exposure, and the susceptible populations. A handful of studies have demonstrated an association between first or second trimester exposure to nitrogen oxides, fine particulate matter and ozone, and GDM. Alternatively, others have reported an association with impaired glucose tolerance rather than occult GDM. And another study has only found an association in a subgroup of the pregnant population, namely those with a younger age. In terms of the mechanism, we think that there's some biological plausibility here in the systemic inflammation and oxidative stress that fine particulate matter can cause, and the way that it impacts the stress hormones such as cortisol and alterations that may occur in the adipose tissue, which affects insulin resistance. And there's broader evidence around air pollution and diabetes generally, which supports this association and certainly tells us that we need to be looking further into this. So there's emerging evidence around ambient air pollution and type 2 diabetes, as well as episodes of hypoglycemia during severe smoke events, and more broadly, metabolic syndrome and obesity. So there's coherence in the evidence that tells us that this certainly needs to be unpacked further. And as public health officials, understanding this is particularly important because we need to be able to provide advice to the public when severe smoke events occur and make sure that we're tailoring that advice for important vulnerable subgroups of the population. Previously in the past, pregnant women had been overlooked as a particularly at-risk group, and the focus had been on, say, those with chronic respiratory conditions or heart disease. But we are recognising more and more the health harms of air pollution in this group and the need to tailor advice. Off the back of this work, we worked with RANZCOG, the Royal Australian and New Zealand College of Obstetrics and Gynecologists, and developed an air pollution and pregnancy fact sheet, which is available online and in plain language sort of highlights what is known around air pollution and pregnancy and steps that pregnant women can take during smoke events. And of course, it goes without saying that there's broader public health measures which are needed to mitigate potential health harms. So I'll stop there and thank you.
Thanks very much, Shannon. I think that was a really great example of the complexity of actually teasing out some of the associations and what it takes to run a study in that space. And so I know Camille sort of provided an overview of a whole bunch of studies, but there's a lot of complexity in those individual studies. So thank you. And agree that there's a rapidly emerging literature around the link with metabolic disease more generally in this space. And so I agree that this would be consistent with that. So now we have some time for a discussion and some questions, probably about 10 minutes. So we give everyone an opportunity to have a comfort break before we start the next block of talks. So we have some mics in the room. If you have a question online, Faye's monitoring that. Open up for questions. Yep. Thank you.
I'm Jeff Blewett. I'm from here in New Zealand. Hey, it's fantastic to be here and watching you health nerds tell us what the effects are, because people who run models and do the monitoring, we just look at the guidelines and go yay or nay. So fascinating 3 presentations. My dilemma is the 3 of you said there are effects. And so if I'm dealing with a situation at the moment where a quarry is expanding closer to a residential area. And if those people were sitting in this room, they would be raising bloody hell because there's all these effects. So I need help from you to tell me where the effects begin and how those align with the guidelines we currently have. Is that an easy question to answer?
Well, that's a fascinating question. I don't know whether Camille or Shannon, I don't know whether you want to have a response around that and around public health guidance, because it's a space that you play in. I have some thoughts and I might throw to some others as well. Did you want to have a go at that one to start with?
Yeah, I'm happy to start. I think my occupation is a public health physician, so we very much deal with the interface of public advice and trying to translate research into the actionable steps for the public. I think it's really challenging in this space because we recognise that in the expanse of environmental determinants and exposures, as well as lifestyle factors and others that influence an individual's health, we need to strike the right balance of providing advice that is actionable for an individual, that's within their control, as well as address those broader kind of policy and advocacy factors that I mentioned as well. So it's for us along that continuum of education, making sure that it's something that the public are actually empowered to do, that they understand that we're not causing harm by providing advice. I think it can be harmful sometimes to provide advice that the public can't act on, and we see that play out with relocation advice during fire events, which is something that not everyone is able to do. And then down the other end of the spectrum is those sort of broader levers that we have around policy, legislation, the national environmental protection measures, etc. So I'll probably just open with that kind of broad commentary around the challenges and our levers, and go to others.
Thanks, Shannon. That was a wonderful response. Did you have anything you wanted to say and follow up to that, or just happy for us to continue to? Yeah, well, I don't know, Faye, if you wanted to chime in on this discussion at all.
I could probably say a couple of things, and I know you can too, but
Yeah.
I think one of the key things about air pollution is that at any one individual level, the effects are small, they're normal responses, physiological responses, but everybody breathes the air, and at a population level, it gets really important. And the difference between the individual and the population is always one that's hard to communicate about. So you get a lot of anxiety about deaths and terrible complications, but really it comes down to the entire mix of risk factors that's affecting one individual, of which air pollution is just one. So that's something I always try and communicate, and it's difficult to communicate. The other thing is the message that we have by having regulatory standards. Maybe you want to say something about that one, Graham?
Yeah, so I think the challenge with regulatory standards, particularly in the frame that we currently operate in, is it by setting a threshold, you're sort of perpetuating the perception that anything below that is safe. And we know that actually the best approach to mitigating against the effects of air pollution is a continual reduction approach, which is being adopted in other jurisdictions around the world. And so we also know that, I know we're talking about other organs today, but in the respiratory disease and the cardiovascular disease, you can track health effects effectively all the way down to zero. So we know that there is no true safe level of air pollution per se. But as Faye has pointed out, there's a pragmatic question here about what people can control as individuals, what we can regulate, and what's an appropriate framework from that. How do we, is our framework of setting a threshold right, or should we be setting reduction targets? Are we monitoring, is there a monitoring network sufficient that we can actually effectively manage that? And so there's a whole range of questions in there. So I think it's a really fascinating topic. That's something that the centre really plays around in. Yeah, Faye, did you want to add
Can I
to
say
that?
one more thing?
Yeah, of course.
There's another key factor in all this, and that is with air pollution, as the others have explained, the harm you get to yourself is from your own physiological, perfectly normal responses. They kick in instantly. They'll kick in every day with stress, with all sorts of things. But then they kind of reach a maximum and plateau. So the big window for protecting health is actually, for PM 2.5, it's between 0 and 30 to 50. And thereafter it starts tapering off. So if we as public health officials only focus on the rare extreme events, which are important and do have huge public health effects, we're actually missing the boat a little bit, because the huge opportunity for improving population health is actually our everyday air more than the rare extreme events. A bit like sugar at parties. It's what you eat every day. Regulating children's parties isn't going to give you much of a public health benefit.
Thanks, Faye. That's really well. And I think Shannon's data quite nicely shows that it was an extreme event, but actually the absolute exposure levels for the individuals weren't actually that high, and you can still detect an effect. Camille, I'm interested in picking your brain a little bit around that and kind of joining the sort of public health message piece around that, because you quite clearly articulated, and it was also evident in Shannon's data, that there are particular trimesters or particular times in development where there are specific susceptibilities, and how you manage potentially targeting message on the basis of those susceptibilities, or are you better off having a broad message around protection from exposure to air pollution?
Yeah, I think probably a broad messages around protecting yourself is probably the best at this stage. We don't really have a lot of really good evidence about what helps protect people as well, helps protect pregnant women. And we really probably do need to have a better understanding of that. So, some intervention studies would probably be really useful. We have to be a little bit creative, I guess, and think about what interventions people can actually use, and from what other fields, if there's other fields that we can draw some evidence from. There was the recent call from the NHMRC looking at climate change as well, and there was some I was on the panel, and there's some great plans in there. And so that's specifically looking more at heat, which is obviously a component of this. Anyway, so I think we just need to look at some ideas for policy change. And again, it's big picture stuff, isn't it? So we need to improve the air quality in general. And that's more about industry and everything else out there. So it's complex, right? And we don't have a lot of evidence.
Yeah, and that's why we're here having these sorts of workshops. So thank you, Camille. And I think the other thing that I just want to put on the table that I do think is perpetually forgotten is at the treatment end. And so there's almost no research trying to understand whether, for example, and I'll take a respiratory example, whether the treatment for an asthma of someone with asthma who's having an exacerbation for a virus is the same as someone who's having an asthma exacerbation because of air quality. And really, there's almost nothing in that space. And so I think that's something that's often overlooked. We've probably got time for one more question in the room or online. Back here.
John Ennis, EPA Tasmania, and I won't stand up. It's a question, I guess, for Shannon, and really great to see the results of that study. The Hazelwood was such a big thing and so many people involved. So to see it really hard set of numbers is great. But my question for Shannon, and I'm not suggesting you redo another PhD, the increase in your effect when you went from the mean to the peak looked quite marked. Now, of course, the mean has all those days where you don't have any smoke and the peak is only one day. Potentially, and by the sound of it, you'd have enough data to actually say threshold it at some level and look at the number of hours above that threshold as well, which would capture both the extreme and also the duration, which you don't get either other way. I just wonder whether the effect might even come out even stronger in that case, for example.
Shannon, did you get that?
Yeah, thank you. Thanks, John. That's a great question. I think gets to that granularity of our exposure assessment and yeah, coming back to the data and relooking at how we assigned exposure. And I think it would be worthwhile to do. One of the limiting factors for us in this study was the Latrobe Valley being a regional centre. We had a fixed population, and so any of the kind of, as we were teasing into sub-analyses and sensitivity analyses in the work, the precision estimates got wider and wider. But I think, yeah, it's certainly a really good point. We did come at looking at different ways of assigning exposure through, as we were doing it, but we certainly didn't look at it in the level you've described, and I'd be curious to do so, but without another PhD.
Thanks, Shannon. And you join me in thanking Camille and Shannon for their presentations today. We're going to now have basically a 10-minute comfort break, and so we'll reconvene at about 10 o'clock for the next session where we'll be talking about something related but slightly different. Thank you. Thank you, everyone. We might get the next session underway. So in this session, we have 3 talks that are focused on brain health and cognitive function, which I think is a really interesting topic. And in the context of the introduction that I gave earlier, exposure to the brain has the added challenge for a particle in that we have something known as the blood-brain barrier, which is essentially a more robust mechanism for brain protection in the cardiovascular system. And so it's interesting to think about how particles might then influence these sorts of things. And we're going to hear from, first up, Professor Anthony White, who's going to talk to us about the impacts of bushfire smoke on brain health. Thank you.
Thanks very much. And thanks to the organisers for inviting me to speak here today. So I'm going to talk about the bushfire smoke impacts on brain health as an example of air pollution and how it affects our brain. There's a lot of evidence out there now that air pollution has very strong effects on brain health. And as you can see on the left here, there's a lot of different impacts that air pollution can have on the brain. A lot of studies are coming out now around how air pollution impacts the brain in terms of neuroinflammation, inflammatory responses in the brain, inducing stroke and so on. There are also studies showing that there's increased impact of landscape fire smoke or bushfires, wildfires and so on the brain. Most of this is coming from either animal studies where they expose mice to bushfire or wildfire smoke, and also changes in cognition in people who are being exposed to wildfires or increase in stroke and so on. We're particularly interested in how landscape fire smoke affects dementia. This is the number 2 leading cause of death in Australia in men, and the first leading cause of death in women in Australia. There's increasing evidence that air pollution has a very important effect on dementia, and the study showing that interestingly, air pollution is the second highest modifiable risk factor for changes in the brain that are related to dementia And you see there that dementia is the first modifiable factor. And from the talk we had previously, indicates that there may be very important links between air pollution and diabetes to drive those changes. So there's also studies from the US showing that agricultural particles, which are probably involve things like chemicals and agricultural pesticides and so on, and wildfire smoke are the two leading factors that can drive changes in dementia in people in the US. So we're trying to understand how this impacts the brain, and we understand that the smoke particles, which contain a lot of different changes, volatile organic chemicals, nitric oxides, metals, PAH and particles and so on, can potentially access the brain through the olfactory system and also through lungs and the blood and into the brain. And we really want to understand how this affects the human brain. There's been some studies, as I say, on animal models, but very little done around humans. So one of the things that we're looking at is microglia in the brain. Microglia are the key immune cell in the brain. So they're involved in inflammation in the brain. We can generate them from monocytes from the blood by taking cells from people and isolating them and treating them with various compounds so we can get microglia to grow in culture from individual people. And we can do this fairly routinely, as we've published a number of times. And so we've generated what we call a bushfire smoke extract by burning various Australian vegetation material and collecting the smoke through the culture medium. Then we can put it on the cell cultures and comparing this to diesel engine pollution from QUT through the same process. And we're now also moving into looking at particles collected on filters. Some of this is from the bushfires from the Black Summer, and you can see with the changes in those filters compared to the controls, and we're just starting to look at this now. If we put this bushfire smoke extract onto the brain microglia at high concentrations, we do see cell death, but at low concentrations, they don't kill the cells, and neither does the bushfire pollution. And that's kind of what you expect. You wouldn't see massive death of cells in the brain. Otherwise, people would probably die very quickly from breathing in smoke. But what we do see, we expose the microglia, the brain immune cells. We see a slight upregulation of nitric oxide, which is something that microglia release in response to stimulation. We actually saw increased response from the diesel engine pollution in that particular assay. Both in young people and older people. And also we put this onto neurons as well and sort of seen an increase from the bushfire smoke extract in terms of nitric oxide secretion. We haven't compared this to diesel engine pollution. But what's more interesting is when we look at comparing younger people to older people in release of inflammatory cytokines. So these are molecules that are released from cells and then control a whole lot of other inflammatory processes. So the names there are just different types of inflammatory cytokines. In younger people, we didn't see a lot of difference, but in older people, after 4 days of exposure of the bushfire smoke extract, we saw very strong changes. And this is more obvious here, where in the top panel, you don't see much difference between untreated bushfire smoke extract and diesel engine pollution across the different cytokines. But in the aged cells, we saw very strong responses. And this is just an example here where we saw a 400-fold increase. And sometimes we only see something like a 0.2-fold increase. So this is a massive increase in the release of cytokines, something that is the kind of the highest changes you expect to see from the bushfire smoke compared to traffic pollution, the diesel engine pollution that had no effect at all. And so this massive response that we see is something that can drive changes that then drive further inflammatory responses, that is kind of feed forward cycling. And interleukin-23 is something that is involved in Alzheimer's disease or dementia. We also see changes in oxidative stress, so upregulation of heme oxygenase 1 in treatment with the bushfire smoke extract, and also after a longer period. We do see this with the desalination pollution, but not the prolonged changes. And another marker, P65, which is a marker of changes in inflammatory pathways. And we see that with bushfire smoke in our microglia. And this also drives downstream further inflammatory responses. So these are accelerating processes that if you get driven through these changes, that everything seems to grow from this. Just very briefly, we also see increases in cell death from bushfire smoke in brain organoids. So these are mini brains, so they're sort of a few millimeters across, and they have lots of different brain regions. And we put bushfire smoke on them, we see very rapid cell death of these mini brains compared to what we see with traffic pollution. And factory cells and nasal cells we can take out and grow in cell culture, and these are the cells that are the first cells that are exposed, often apart from lung cells, when you're breathing in smoke. We see an increase in cell death, particularly in people with dementia compared to healthy people. And these cells are very much tied in through the olfactory bulb into regions of the brain that are associated with memory and lots of brain functions. And we did an RNA expression analysis on this. We saw lots of gene changes. And one of the interesting things was that the top genes that were changed in these nasal cells, they were involved in cognitive processes. So because we'd differentiated them into the brain-like cells, we saw changes in lots of genes that are associated with brain function. And a lot of these also in other studies have been shown to be responding to air pollution. So it's very interesting that we're seeing changes that are occurring in cognitive genes that are also known to respond to air pollution. And what we're doing at the moment is trying to understand how the smoke affects the brain function of people who are on the front line, and also tying this into the broader population. And we have a couple of applications in at the moment, looking at how we can understand the neurotoxic effects of different types of bushfire smoke or wildfire smoke around the world on different cells in the brain, understanding how this impacts people on the front line in terms of rural firefighters and wildland firefighters in the US, and then extending this into the broad impact on society and people exposed to bushfire smoke. And then hopefully we can identify markers and so on that we can use to modify our policy outcomes. Just an example of this with the population level studies, we have what we call PISA, the Prospective Imaging Study of Aging at QMR Berghofer, where we have a lot of people who are aging, and we study them in a lot of different outcomes. And we're looking at, in collaboration with Jeff Morgan, University of Sydney, in trying to compare their health outcomes in their brain function compared to their historical exposure and current exposure to bushfire smoke and other air pollution, and also various other lifestyle factors that might impact this. So just to summarize, there's a really growing area of interest around how wildfire, bushfire, and so on smoke impacts dementia as being a major form of air pollution, and trying to understand this from the cellular level right through to population studies, and particularly people on the front line. And if we can come up with outcomes that we can then maybe change the sort of policy documents to advise people on how to protect their brain health over short and long-term periods of exposure to smoke. And just, particularly like to thank the people in my group who've done a lot of this work, and the PISA study, as I mentioned, with Michelle Lupton, and a lot of other collaborators in this area. And thank you.
Thanks very much, Anthony. I think there was some really interesting messages in there, particularly the one that resonated with me, given where I started, was the idea of the olfactory space as a key point of contact and driving the response. And it's also interesting to see there is a common theme emerging around trying to link the health outcomes to what you do in the policy space. So I think that's really interesting. So the next talk is by Professor Lydia Morawska, who is joining us online, who's going to talk about ultrafine particles and the brain, I believe.
Thank you very much, Graham, for the introduction, and good to be part of the session, even so not in person, but I will be in person in the evening in Hobart. Now I'm trying to share my screen. Please let me know whether you can see my screen okay?
Yeah, that's good, Lydia.
Great. Ultrafine particles and the brain. Well, I'll be talking much more about ultrafine particles and everything else, not the brain, but ultimately it is going towards getting more information how the brain is affected. So ultrafine particles in urban environments. What we know, and we've known for a long time, that in terms of number, vast majority of the particles are in the ultrafine size range, which is smaller than 0.1 micrometer. That's by the definition. And actually, most of them are even in a much smaller range. So this is very significant. These particles are very small. And we basically know nothing about these particles if we measure pollution, particulate matter, only in terms of mass concentration, which is PM2.5 and PM10. So this is one point. Now, how do we characterize ultrafine particles and the complexities related to this? Unfortunately, these complexities, they haven't been decreasing over the years. Now, here is the scanning mobility particle sizer to measure very properly particle size distribution. And these instruments are as complicated and as expensive, very to stress, as now as they were when I first started a long time ago in this field. Basically, anything to do with ultrafine particles is very complex because they are so small. So what we've been all the time thinking about the impact of these particles or any particles on the body is through the entry and exposure through the respiratory tract. So that's the respiratory tract, and then we were talking about particles which are inhalable, thoracic, respirable, and for the long time this was considered to be the most important pathway of exposure. This is a textbook size distribution in terms of deposition of particles, and you can see that the smaller the particles, the more of them deposit in the deeper parts of the respiratory tract. This has some examples from our experimenters, different type of diesel smoke with the decrease in size of the particles, high fraction is deposited. So that's what we, and then from the deposition in the lung, the idea was the smallest particles then penetrate through the epithelium and then eventually get to all around the body, including the brain. Now, we've done some studies, others did as well, in terms of the impacts of exposure on ambient particulate matter, ultrafine particles. And one of the outcomes from our study, that was study on children, 25 schools in Brisbane area, large metropolitan Brisbane area. What we saw, they do not affect respiratory health. However, they have systemic effects. So that was the considered penetration through the epithelium, and then the discussion how it was done. So as I said, this has been thinking and recognition in this, but it's not that the issue of direct penetration through the olfactory system to the brain has not been mentioned. This is probably one of the first study, 2004. And I remember then looking at this study and I thought, okay, that's interesting, but not really many people talked about this. And in any case, it was finding out which way those particles got into the brain would have been extremely difficult. We knew how to measure particle size distribution and the positional fraction. But then what happened then, and proving this doing actually exposure, including, for example, tracer methods, that would have been very difficult. So that's one side of the story. But then the other aspect of the story is that if we know so little and if we cannot quantify particularly exposure-response relationship, it's very difficult to move that whole area of ultra-fine particle any further. So in the WHO guidelines 2005 edition, which is the one just before the recent one, 2021, there was the only mention of ultrafine particle was this, and I'm pleased that I wrote this, but this was the only one, the only statement which I managed to get into that document. While there is a considerable toxicological evidence of potential detrimental effects on ultrafine particles on human health, the existing body of epidemiological evidence is insufficient to conclude on exposure-response relationship to ultrafine particles. Now, we have exposure-response relationship to PM2.5, also to PM10. This is how it looks from the acute respiratory infection. This is one of the study which was part of the preparation for the current WHO guidelines, data from 41 different cohort studies. So this is an exposure-response relationship, but we don't have nothing like this for ultrafine particles because basically no exposure-response study have been conducted because of experimental complexities. But there is a progress. Well, before this, so it's very clear that until we have exposure-response relationship on ultrafine particles, no guidelines, numerical guidelines, WHO guidelines are possible. But the progress which has been made is that in the current edition of the WHO air quality guidelines, we have good practice statements, and one of them is on ultrafine particles. So black carbon, ultrafine particles, and desert dust, and those particle types were included because, on the one hand, insufficient evidence to quantify, to provide quantitative guideline levels, but there are strong pointers to their health effects. So they come from different sources. Ultrafine particles come from combustion, but also secondary processes. So the fact that this statement is now, and there are a few pages of this and elaboration, this is progress. But one of the statements in this document is this: efforts should be stepped up to utilize the emerging science and technology to advance approaches to the assessment of exposure to ultrafine particles for application in epidemiological studies and management. Now, it may sound like a motherhood statement, okay, use emerging science and so on, but it's actually point out that look for ways sort of out of the box so that you can get some information, saying that if you want to do it using the methods we've used so far, like SMPSs, which are difficult, costly, and so on, this field is not going to move. So this opens the door to kind of new science. And I'm pleased to say that the project like this to support WHO guidelines, good ultrafine particles, good practice is underway. Now, the aim of this project is this. We'll conduct a year-long monitoring of ultrafine particles in locations around the world using the Protector 2 Pro. Now, I'll say a few words about this in a moment. Well, first of all, to demonstrate its comparability and what it is with this complex system, MPSSs, quantify to the extent the size distribution varies from this particular EU standard, but also, very importantly, demonstrate its robustness in terms of long-term stability, operation, and ease of operation. The way it is right now, using SMPSs, it's not possible. Let's say you cannot put them in a monitoring station because there's no one to operate them. Data losses are up to 50%, any project run them, so that's not a solution. This possibly offers an option. Now, the instrument is a kind of a progeny of instruments we've used, disk mini nanotracers, they were called before. It's operates on the same principle. I'm not going to go into this. One important aspect is that, like the predecessors measures just total particle concentration, this has 8 size channels, and very importantly, this will allow us to have information in what size the particles are, which means what they are, whether they are secondary particles or potentially primary particles or aged particles like landscape fires. So as we speak, and not quite, I think it's tomorrow, at the same time as our conference in Hobart, in Tampere, there's the European Aerosol Conference. And this poster, this abstract will be presented as a plenary presentation, and tomorrow, our time in evening, there will be a meeting of this group. So the conclusion here is what we expect is that successful completion of the study will be a step towards future prospective exposure response studies focusing particularly on the impact of ultrafine particle on brain health. So it's not that the mechanism, we are not going to study the mechanism this way, like the previous presentation explained, but this will be the epidemiology. So thank you very much. I'd like to add something which I will mention in my presentation at the closing session. This whole issue, why this topic of ultrafine particles ended up in the WHO quality guidelines, is because of this thinking outside the box team, which I convened after the indoor air conference in Casino. That's image of the casino. We generated this white paper, served as an input to the WHO practice on ultrafine particles. Thank you very much for your attention.
Thank you so much, Lydia, for that wonderful presentation and for the overview of where this space is heading and how you're helping to address some of the gaps. And I suppose that's one of the other purposes of the session today, to identify where the gaps in knowledge are. And clearly in this space, it's about measuring the right thing to get the exposure response. So it's really interesting. We've got one more talk in this session. Before then, we have some time for some questions and discussion. So the next talk is by Richard Martino, who's in the room with us today, who's going to talk about air pollution and educational outcomes.
Today, I'm going to talk about air pollution and educational outcomes, mostly focused on the ambient air pollution, so that kind of background every day. So first, I'll go into air pollutants and a kind of general overview of childhood neurological development. I'd like to thank all the other presenters for going into more detail into the biology, and then going through the current research and then knowledge gaps and possible next steps. So why are children at an increased risk? They are rapidly developing. They spend more time outdoors, breathing closer to the ground, and they breathe more rapidly and take in more air when compared to adults. And so this is a very simplified possible biological mechanism image. And so when we breathe in air pollutants, it has the possibility to go through two pathways, from the nose to the brain, or inhale through the lungs and into the bloodstream and making its way into the brain, or as we've heard, across the placenta. And so the United States EPA produces a report to summarize the current research and the rates of the likelihood of having a causal relationship of certain pollutants. And so they rate it from no relationship or not enough evidence to causal. And as we can see in the red box for the nervous system, PM 2.5 for long-term exposure is likely causal for negative health outcomes, and then ozone is suggestive for both short and long-term. I would like to point out that this was done in 2016, so there's been a lot more research that has been done. And so reducing air pollution for educational success is important because for short term, it can help improve students' concentration and behavior, lead to possible future academic opportunities and confidence in learning potential, and then later in life, leading to possible better quality of life and earning potential. And so to bring in an example, so these are school buses that can be found all over the United States. There was a really interesting study that came out this year that from the University of Michigan and the University of Washington, where they looked at school bus replacements. So the EPA randomly selected school districts and replaced older school buses for newer ones. And so when there has been a kind of change in fuel standards, and they found that when school districts replaced the older school buses, there was an improvement in reading and math scores. And they attributed this to the reduction in exposure to air pollutants while riding the bus, as well as idling school buses around schools. So now to go over some current research, we're currently in the process of conducting an umbrella review. The protocol has been registered on Open Science Framework, and we've searched 6 databases using search terms developed with help from a research librarian from the University of Tasmania. And now we're currently screening and extracting the data using a program called CASANZ. And then we plan to summarize the findings and publish our review in a peer-reviewed journal. The eligibility criteria for these studies were studies that focused on children and adolescents, short and long-term exposure to ambient particulate matter, nitrogen dioxide, and ozone. So this did not include other metals or other pollutants such as metals or extreme events such as bushfires or wildfires. And we compare that to exposure to lower concentrations of air pollutants. And we have 4 main outcomes: academic achievement, attention deficit hyperactivity disorder, autism spectrum disorder, and behavioral issues. And so today I'll just focus on the academic achievement. And we focus on systematic reviews with and without meta-analyses. There were a total of 46 studies that came out of these systematic reviews. And so I focus on the 3 most recent systematic reviews. And the study designs were mainly cohort studies, followed by cross-sectional and a few ecologic studies. And the main exposures were particulate matter, nitrogen dioxide, traffic-related air pollution, which acts as a kind of umbrella term for many different pollutants, and ozone. And then the outcomes were test scores, intelligent testing, reaction time, working memory, and attention. And so this map shows that a majority of the studies take place in North America, Europe, Asia, and then a bit in the UK, Australia, and then Central and South America. So as a kind of overall summary of the key findings, most studies found an association between particulate matter and a decrease in memory, attention, or test scores, while the risk of negative educational outcomes due to the exposure to nitrogen dioxide and ozone were not as clear. So some studies found statistically significant differences between the exposure groups and some did not. And when looking at traffic-related air pollution, there was an association between exposure and test scores. And to give one example from a study in Spain, they found that PM 2.5 exposure contributed to an estimated equivalent to 1.1 month delay in age-appropriate improvement in reading speed. So that's just one example to say that while it may not sound like a major effect, there is some health effects that have been seen. And then now to go over knowledge gaps and next steps. There are many studies that look into green spaces and have found that there's an association between green spaces and educational outcomes. However, few studies that look at air pollution as the exposure use green spaces in their models. Then for socioeconomic status, most studies use maternal education as a proxy for socioeconomic status, which may not consider resources at the schools or maybe the socioeconomic status of the neighborhoods where the children might receive some other support. And then most studies are small sample sizes, which may not be large enough to detect differences between the groups. Then possible next steps. There are opportunities to educate people in the communities, develop policies to reduce concentration levels of air pollutants, and given the knowledge gaps, there is a need for more research. This image on the left is an example from the United States EPA. They have a campaign about idle-free schools, and this is to educate bus drivers and parents not to idle and expose children to further pollutants. So to summarize, current research suggests that exposure to high concentrations of air pollution for children and adolescents has effects on the brain, and a growing number of studies have shown that the exposure to air pollution is associated with negative educational outcomes. Thank you.
Thanks very much, Richard. Clearly, like some of the other talks in this particular session, there is lots to do in this space and a lot of unknowns, and so I have some specific questions around that. But this session is now kind of open for questions and discussions, a little bit like the last session we had. So about 10 minutes or so. Does anyone have any questions in the room or online? If not, I'm happy to start with some questions. So maybe I'll put this question to all three presenters. Hopefully you can hear me online, Lydia. Clearly, this is one of the areas of the alternative health effects of air pollution where it's rapidly growing, but also there are considerable gaps in this space. And I might ask you individually, what would you see as the next most important thing to do? Because you've all kind of talked about slightly different aspects of the question around the link between air pollution and brain health. And so perhaps you were first, Anthony, and maybe I can go to you. If you, what do you think is the most important gap that should be addressed next in your space?
That's a very difficult question. There's so many gaps, and I think we're just starting in this area to understand all the different types of air pollution and how they affect people's health. And I think, from what Lydia talked about, ultrafine particles is something that is a really important area, and it's almost ignored because it's too difficult to measure and has no sort of defining controls around it. I think that's something that we really need to understand, just what the different types of particles are in air pollution and how they affect different parts of our health. We need to understand everything, not just identify one part of the air pollution and control that.
Lydia, did you have a follow-up response to that? Have we lost Lydia? Okay, she may hear. If not, maybe, Richard, do you have any thoughts on that particular question? Are we happy to pass the microphone? Thanks.
This probably not related to my presentation, but I think one interest I have is around transport. And I know there's a recent study that came out in New York City looking at subway stations and how the concentration levels were very, very high. While, I don't know, living here now in Hobart, I can bike to work and breathe in relatively fresh air. So I think looking at how people get to work and transport and their exposure risk is an interesting area.
Thank you. Any questions from the audience? Oh, there's one over here. Bill, are you happy to pass the microphone?
I'm Lynn Dennison from Jonkin and Taylor. I guess this is a broader question to everyone. The effects on the brain and cognitive development and are known for noise, odor effects as well, and air pollution. So how do we make sure that we address the cumulative effects and not each one individually? Because each one of them is going to have an impact on health?
Yeah, that's a great question, and also some of the and you I think Anthony and Richard, you both alluded to it. There's the direct effects of health of air pollution plus the indirects of all the other things that it affects and what that does to brain health. So I think that's a really great question. How do you kind of come at this from a holistic point of view? Any thoughts? And anyone want to offer anything? Anyone else want to offer anything in that as in the spirit of an open discussion?
Yeah, it's a really great question. There's so many elements involved in not only clean air, but green spaces, access to natural environment and so on. Trying to understand how all these interplay, it's really difficult in terms of particularly in things like people's brain health, noise, how close you live to roads, and how that affects air pollution, but also noise levels and so on. I mean, we're just starting to understand how these things affect people from anxiety, depression, and other mental health issues, and direct impacts on the brain from particles and so on. There's so many things that we need to do. It's really, in some ways, it's quite daunting, but it's also quite exciting in terms of what we can explore.
I think the other challenge you have in the brain health space is as a health outcome, it has a long latency, and some of the effects don't have an immediacy, versus I'm an asthmatic, I breathe some smoky and I feel I have some difficulty now, versus this is going to affect your long-term brain health, risk of dementia, educational outcomes, and the challenge that comes in I suppose in the public health space as well. Faye, I saw you turning on the microphone. You don't have anything to add at all to this, the complexity of how you address it all?
I was just going to say the field of research is wide open and there's lots of questions and they need to be addressed at every level, from mechanistic through to epidemiological. I was going to ask Richard an aligned question, if you remember, and if you can tell us from your review, the different results between short-term pollution exposure and a test score on the day compared to pollution over the previous year and test scores throughout the year. Are you able to make any comments? Were there any differences? Were results seen with both durations of exposure? Or you might not be able to tell me at this point.
So I can tell you, I guess briefly, it was mixed. So there were studies that looked at exposure on the day and did find significant results. But most studies looked at the yearly average background air pollution and then exposure, and then test at a single point.
Thanks. So that speaks to all the different short-term, long-term mechanisms.
Yeah, all those things. Yes. We do have time for one more question. If anyone has a burning question, have we got? Thank you.
G'day, Paul Tocco, EPA Victoria. It's one of the things for us as regulators is the application into policy. I mean, how is this material, one, for education and changing people's behaviours, but secondly, in urban planning? Are you influencing the design and the way people and the cities and the schools and the way that they're using this information to say that there is a problem? I think one of the things we're trying to come to grip with, especially a lot of wood heaters, is people think smoke's fine. It's because this biology is really interesting, but how do you translate that to make a difference in terms of influence? And is there any sort of that bridging that gap?
Yeah, that's really aligned to that sort of question and all of the levers that you can pull to change the outcome. Anthony, Richard, do you have any responses to that before I throw it open more widely?
Sure. I think one thing that comes to mind is, well, it may be hard to change individuals' beliefs and actions. There are more studies coming out around green spaces and showing that even having the green spaces allow for almost a filtration of air pollution. So being in those spaces, and maybe from a more urban planning or city planning, could have an effect.
And I know one of the areas of focus in the Centre for Safe Air is this idea around buildings and urban planning, and how where do you put a school in how that potentially affects those sorts of health outcomes, and mixing that with green spaces and various other things. So there is a lot of active work in that space. Anthony, did you have anything to add to that before I close?
So we have this view that smoke is something that we've lived with for all of our sorry, we've lived with smoke for all of our history, and then for, how can it be something that's bad? But, I just say to people, can you sit in and smoke coming into your face and breathing it in around, a fire or something like that? You always try to avoid it. It's a human response naturally to avoid breathing in smoke. And that suggests after, 1 million years of evolution, we don't want to breathe in smoke. And yet we are forced to do that on so many situations at a lower level, but, we just do. And clearly there's a reason why if you have a major smoke impact on your face, you go, no, I need to get away from that.
It's a good point. And also, I think it is worth thinking about the fact that the people who are disproportionately affected often have very little control over the source of the pollution that they're being exposed to. So I think that's an important sort of point to finish on. Well, that's right on time for the finish of this session. We now actually have a 15-minute break before we start the next one. So please take the time to have a bit of a comfort break. Get some. Did you want to add to that?
Sorry.
Yeah.
If you weren't going to say the coffee and tea's out there too.
Yes, there you go. Yeah, good coffee and tea's out. Please feel free to bring that back in here too to be the same part of the conversation. Thank you very much. All right, we might get underway because we're on time. So this session we're going to be covering 3 distinct disease phenotypes, and so we're going to be hearing someone talking about cancer, bone health, and eye health. So the first speaker who's joining us online today, Associate Professor Peter Franklin, who's going to talk to us about cancer and pollution. Thanks, Peter.
Thanks, Graham, and thanks for inviting me via Jane Hayworth, but I'm happy to be presenting. I'll just share that. Okay, thank you. Okay, so my brief is talk about air pollution and cancer, and just first acknowledge that I am speaking from Perth, and I am on Wajak Noongar Bodja. So people may or may not be aware that the idea that air pollution was associated with cancer was put forward many years ago, back in the 1940s. And this is actually from the introduction of the seminal paper by Dole and Hill on smoking and lung cancer. And they, at the time, had sort of postulated that the 2 possible causes of an increase in lung cancer that had been observed in the UK was either a general atmospheric pollution from exhaust fume of cars, surface dust of tarred roads, and from gasworks, or from the smoking of tobacco. And as you will know, it was very clear that smoking was an important cause of lung cancer, and a lot of work then went into smoking and not so much into air pollution for a few decades until the 1980s and 1990s. Work since that time to the International Agency for Research on Cancer to classify outdoor air pollution as a group 1 carcinogen for lung cancer. So air pollution as a mixture and particulate matter specifically. And the evidence for this was pretty strong. It was sort of based on the human evidence, the epidemiological evidence, on experimental evidence, the toxicology, and also from mechanistic data. And just to make clear, I won't talk any mechanisms in this 10-minute talk. They also at that time had said there was a positive association between air pollution and bladder cancer, but didn't have enough evidence for it to be a sufficient cause as a group 1 carcinogen. The important studies at that time were long-running cohort studies, and 2 in particular, the American Cancer Society Cancer Prevention Studies that run in the US, and then in Europe there were the ESCAPE, which was a conglomeration of a number of studies across all of Europe. And the reason important is because they had a good range of exposures. They had reasonable estimates based on the land use models that were being developed at that time. And they also had detailed information about confounders. They were very large cohorts. And one of the confounders that they sort of take into account was smoking, which of course is cancer. And one of the is the ACS, the Cancer Prevention Study. Second one showed an increased risk of lung cancer in non-smokers. What's happened since that time? The evidence has only got stronger with regards to lung cancer. So the estimate, there's an increased risk in that meta-estimate. There's ongoing consistency. There's been more studies outside of Europe and the US, and an increasing number of studies in low air pollution regions. And I'll come back to that towards the end of this talk. What about other cancers? So, this is beyond the heart and lung. So it seems that it's very strong evidence for lung cancer. Since the IARC publication, there's been a few more studies in bladder cancer. Again, most of them showing a positive association. The risk ratios, that the increased risks are quite small, but seem to be consistently positive. This is both for particulate matter and for NO2, and NO2 often is used as a, as you know, as a proxy for traffic pollution. Kidney cancer, another one. So again, an increasing number of studies all tend towards the positive side. The meta-analyses that have been done are showing a positive association with it. Still not enough data for it to be called a sufficient cause, a group 1 carcinogen, but the evidence is increasing. Similarly for liver cancer, far more variation in the results of these, but the research is ongoing in these different sorts of cancers. And breast cancer. So the interesting thing with breast cancer is that most of the consistent findings have been for either measures of nitrogen dioxide or NOx levels, or proxies of using traffic-related air pollution models as a proxy. There seems to be, from the outdoor air pollution point of view, little evidence for it from for particulate matter, which is interesting. And the breast cancer risk. I'm just going to shift a little bit. I'm going to shift from outdoors to indoors. This is predominantly about outdoors, this session. Indoor air pollution, as most of you in the audience will know, has been an area of concern. It's now sort of come back to the fore, particularly because of COVID and infectious disease transmission. For a long time, which is good because it's bringing a focus back to the indoor environment where we spend a lot of our time. And as far as cancer goes, there's a lot of evidence, and it's a fairly established, that household air pollution, so household air pollution as opposed to indoor air pollution in high-income countries where we are, household air pollution is the burning of biomass in low, middle-income countries or anywhere, but that's where they get very, very high levels of pollution indoors. And that has been associated with different sorts of cancer. But very little work has been done on the indoor air pollution and cancer in high-income countries. So, excuse me, there was an ongoing cohort study called the US Sister Study. This is about 50,000 women aged between 35 and 74. And they all have a sister with breast cancer. So I guess there's a familial risk there. And one of the things they've done in the study is ask them about the home environment and indoor heating and cooking sources in the places that they've lived since they were 20 years old. And they've looked at a couple of cancer outcomes. And in the first follow-up that they did, which was 2014, or published in 2014, what they showed was having a wood-burning stove, excuse me, in the place they'd lived for the longest time was associated, sorry, was associated with an increased breast cancer risk. You're going to have to put up with my voice. I've swallowed something. And then a few years later, they did a second follow-up and showed that the number of days that they used a wood heater was associated with an elevated rate of lung cancer. So these are the first studies to sort of show some association with potential indoor pollutants, assuming that these residential wood heaters increased indoor air pollution. So they didn't separate the indoor from the outdoor. It's just based on the use of the indoor water heaters. As we know, and as has been spoken here, and there was a very good first question there about this no threshold issue for air pollution and what does that mean for health effects. For air pollution, particularly PM2.5, we work on the no threshold linear or supralinear dose response relationship. And that's we know for some health effects like mortality, and here's just a couple of slides of that relationship between annual PM2.5 and mortality and daily PM2.5 and mortality, and both show a non-threshold relationship here. So does this hold true for other health outcomes such as cancer? We've just recently done a study in Perth, and Perth's a good place to do this because we are a very low air pollution city. This was a study in aging men. It was called the Health in Men study. About 12,000 men recruited in the late 90s, and they were followed up until 2018, and we were getting cancers from Cancer Registry. And these are the results from there. And as you can see from the actual air pollution levels, very low, well below, well, generally below the NEPM. But what we showed was that, what we found, not show, we found that there was an increased risk even at these very low levels of air pollution. So just to sum up, air pollution is a cause of lung cancer. It's positively associated with a number of other cancers, and I just showed bladder, kidney, liver, and breast, but a few others have been investigated, and that there may not be a safe threshold for that association. So we might have that non-threshold linear dose response relationship for cancer as well. Thank you.
Stay online. There'll be time for some questions after the next couple of talks. Really appreciate that overview of where we are with the cancer, and particularly like the exposure response relationship data you showed at the end, which I think is helpful for this discussion. So the next talk will be from Dr. Dhiren Pillay, who will be talking about bone health and air pollution, perhaps an unusual relationship between.
Thanks, Graham. Thanks, everyone. So yes, I'm Dhiren Pillay. I work with Faye Johnson and others at in the N-Health group at the Menzies Institute of Medical Research. And yet today I'm going to be talking about air pollution and bone health. So thank you for the opportunity to present today. So jumping right into it, what is bone? So bone is essentially a protein matrix that acts as a scaffold for calcium and phosphate and other minerals. And it's got many important functions, mainly protecting internal organs, facilitating movement, supporting the body, but it's also involved in the production of all our blood cells and an important store and release of fat. At the cellular level, bone is constantly being broken down or resorbed by cells called osteoclasts, and it's also being constantly laid down by cells called osteoblasts there on the right. And this is a process that's happening continually over time and is affected by many mechanical factors like physical exercise and hormones like vitamin D, estrogen, testosterone, and so on. So there's a constant balance between bone formation and resorption going on. So why is bone health important? Well, this remodeling of bone can affect our bone mineral density. If too much bone is being broken down or resorbed, we can lose the density in our bones and increase our risk of developing conditions like osteopenia and osteoporosis. So in osteoporosis there, you can see on the right, we have very low bone mineral density, and the bones become weak, fragile, and at risk of fracture. And the common site for these fractures that do occur at the hip and the vertebrae as well. So in Australia, after having a hip fracture, 1 in 4 people aged over 45 will die within a year, and 1 in 7 people from the community will go to residential aged care within 4 months. So there are some caveats around that data, but it's just to highlight that low bone mineral density and fractures from osteoporosis can have very high morbidity and mortality in the community. So can we prevent this? So just looking here on this image on the left, on the x-axis, we've got the age in years, and on the y-axis, bone mass. And as you can see, over time, through childhood, adolescence, and up until our mid-adulthood years, we're accruing bone mass, and we develop our peak bone mass around the age of 25 or so. And after that, our bone mass begins to decline. And in women, for example, at menopause, there's a lack of estrogen, so that women can be pushed into the osteopenic zone. And there are certain lifestyle factors. I should say that if we can increase our bone mass, this is an important way to prevent us developing osteopenia and osteoporosis. So a 10% increase in peak bone mass can delay osteoporosis by about 13 years and reduce the fracture risk by about 50% as well later in life. So yeah, achieving peak bone mass, particularly in these childhood and adolescent formative years, is one of the best prevention strategies that we have available to us. And things like lifestyle factors, smoking, alcohol, a lack of physical activity, sun exposure, a lack of vitamin D, these things can affect us developing our peak bone mass. But what about things like environmental factors like air pollution? So there have been a few mechanisms that have been proposed linking air pollution and low bone mineral density or bone health. One of those is having, as we know, it can penetrate the lungs and enter the bloodstream and cause low-grade systemic inflammation, and that can impair the formation of bone. The second is oxidative damage to bone cells, and that can impact the remodeling process of bone that I spoke about. And we think that's mainly to do with gaseous pollutants. And it can also disrupt hormone signaling and affect that bone metabolism again. On particulate matter, heavy metals can be carried on particulate matter and reach the bones themselves and cause damage there. So lead, mercury, chromium, and arsenic are some that are implicated. And there's also vitamin D deficiency that can result from reduced UVB exposure, both directly and indirectly. So what do we know? What's the recent research? Well, in adults, most recently there've been 3 systematic reviews and 2 with meta-analyses that have been released. With a number of studies ranging between 9 and 19. And these 3 studies looked at particulate matter, and the latter 2 looked at also gaseous air pollutants. All the studies had, the included studies in these reviews had variable quality depending on the tool that the papers used to assess the quality. So from between low quality evidence to all high quality. So it's a bit heterogeneous. And there was also heterogeneity in the way the studies have been designed, how they were analyzed, the subjects that were included, and various different types of bias within these studies. So the first article concluded that it was inconclusive whether there was a link between air pollution and osteoporosis, but the latter 2 studies thought that there was a suggestive increased risk of osteoporosis and hip fractures, particularly for PM 2.5 and NO2. So what about children? What do we know here? Well, there've been a smattering of studies that have been released in the last 2 decades in children, but it's definitely less studied than adults. And these are mainly looked at things like vitamin D and other proxies of bone health. So these studies looked at children of various ages, so infants up to adolescents. They were mainly cross-sectional in design, looked at both solid and gaseous air pollutants, and looked at things like bone turnover markers, vitamin D, and growth parameters. The results were quite mixed in all these studies, and most of them had very small sample sizes. And again, just to reiterate that not many of these look directly at bone mineral density themselves, so mainly looking at proxies of bone mineral density like turnover markers and vitamin D. So what's being done currently? Well, there's someone in our team called Dr. Lika Sheepers, who recently did a large cohort study, which is currently unpublished and under peer review. But she found that PM 2.5 and PM 10 was associated with low bone mineral density in children in a cohort study that was done in the Netherlands. And in particular, there was a period of susceptibility between the years of 1 and 4, where air pollution was thought to have a more significant effect. These pollutants were thought to have a more significant effect on bone mineral density. So this is an important study because it's, I suppose it's contemporary, but it's also looking at actual bone mineral density rather than proxies of that. And myself, I'm also looking at the evidence surrounding bone mineral density and bone health and in children. And I'm doing a scoping review to map out this evidence to find out what we know currently. So to conclude, this is a very emerging field and the evidence is not exactly clear yet, but there's some suggestion that air pollution, particularly PM 2.5 and NO2, may increase the risk of osteoporosis and osteoporotic fracture in adults. And it may lower bone mineral density as well in children. And this is a very important, if this is true, this is an important opportunity for prevention. So if we can reduce or increase peak bone mass, we can slow or delay the development of osteoporosis and osteoporotic fractures and reduce the morbidity and mortality associated with those. So thanks very much for listening. And I'd like to thank Dr. Lika Sheepers, Professor Faye Johnson, and Professor Tanya Winsenberg for their assistance. Thank you.
Thanks, Darren. Really interesting talk, and I like the way that you sort of almost brought it back to where we started, which is the potential benefits of preventing the health effects and the exposures in early life and how that might set you up for better long-term trajectory and long-term health outcomes. So the last speaker in this session and indeed for the workshop is Dr. Suki Jaswal, who is joining us online, I believe, who will be talking about air pollution and eye health. Thank you.
Hi, thank you, Graham. Not quite a doctor yet. I'm submitting my PhD next month. So maybe next year I'll be a doctor if I'm invited to talk. Would you like me to share my presentation? Okay, so hopefully that's visible for you. So my name's Suki. Thank you very much for the opportunity to talk on this topic. I'm mostly talking about some of my work in the last few years that I've done in my PhD on the impact of smoke on the ocular surface. The authors' names mentioned here, can I just acknowledge all of them at the beginning? They've helped me immensely through all of my projects, including Faye and Megan at the Fire Centre. So air pollution and the eye surface. So can I just start by talking a little bit about what's currently in the literature? And so that's where conjunctivitis and especially allergic conjunctivitis has really been associated with air pollution, the contents of air pollution, so especially the nitrous oxides. So for anyone who has been quite fortunate enough never to have had conjunctivitis, it's usually just a condition on the eye in which it gets red and watery. It can affect your vision, it can affect your ability to drive, takes several days to recover. However, if you have repeated exposure and repeated occurrence, there's limited scope on improving your symptoms and managing the condition. But there's a strong evidence of conjunctivitis in relationship with exposure to air pollution in the literature. And there's also a relationship with it occurring immediately and in the days after, so even a delayed response can also occur, and that was also coming from the literature. The other condition that's very strongly linked between eye disease and eye and air pollution is dry eye disease. So dry eye is incredibly prevalent in the community. Most people will have some kind of symptoms ranging from irritation, grittiness, burning, dry, itchy included in that. And once again, there's an association between dry eye disease and nitrous dioxide, as well as with particulate matter as well of different sizes, and the lag, and there can be a lag as well in terms of the occurring of those symptoms and presentations. And indeed, I've just looked at some results that we've analysed of during Black Summer. We looked at some optometry practices in New South Wales who had people presenting to them during the Black Summer period, and then a control period prior, which is a year prior, when air quality was much better. And there's about 2 to 3 times increased odds of patients presenting with eye surface disease symptoms, eye surface disease diagnoses, and eye surface disease related management. So certainly that was increased during the Black Summer period. Now, the key factor with this is also humidity. So high humidity tends to be quite protective of dry eye disease. So if it's quite a dry environment, you tend to have a lot more symptoms. So there is some literature to suggest that when these studies that show dry eye disease association with air pollution parameters, when they actually accounted for humidity, that association was much smaller. So it's possible that in areas where humidity tends to be lower and they have high levels of air pollution, where we may be more likely to see people complaining of dry eye disease-like symptoms. And conversely, in areas with high humidity, it may mask or almost protect against dry eye disease symptoms. Now, we've conducted a bunch of 3 different types of exposure studies using the fantastic Fire Lab at the University of Tasmania. So this is the one that we can here. Basically, we had participants seated about 1.5 meters from the smoke that was generated in that furnace. We were burning bush fuels. We aimed to have the concentration in the room at about 2,000 micrograms per meter cubed, because that was the highest level that the PM count came to during Black Summer. That was what was found in Canberra. And so we assessed eyes of participants before and after this exposure of 15 minutes. And what we basically found was that dryness and discomfort symptoms were increased, as we certainly expected. Tear stability, now that's a measure of, so we naturally have tears on the front surface of our eye. It means the wettability of the front surface, and how stable they are. So our tears continuously evaporate, and every time we blink, we get new tears. And that's a system that happens all day long when our eyes are open. But what we noticed was that the stability of the tears was reduced after a smoke exposure. And that is clinically linked with having discomfort symptoms and dry eye symptoms. And you'll probably know if your tears are quite unstable, you're probably rubbing your eyes, you may be having some trouble with your vision as well. So that's quite a clinical marker that we use to assess the front surface of the eye. The other thing that we saw was this ocular surface staining. So if you can see these little red dots, red arrows pointing to green dots. So they're indicating what we call staining, which is when we put a dye on the front surface to see where the loss in epithelial cells is on the front surface of the eye. And that was also shown to be increased after exposure compared to before exposure. And then we also took samples of tear film, and then we analyzed it to understand if there are inflammatory mediators that are increased in the tear film. And we did see an increase in the IL-1 beta concentration, which just overall suggests that a lot of these changes that we're seeing on the ocular surface after smoke exposure are probably related to pro-inflammatory mediators, which really does support to the animal literature, which has quite extensively been studied this topic in animal literature. But this is probably one of the first studies of exposure that we've done in humans. Now, the other really big thing with with eye surface is contact lenses. So if anyone in the audience wears contacts or knows a little bit about them, you wear them on the front surface of your eye. It's a form of vision correction. But as your eyes are open and exposed to the ambient air, what's happening with the contact lenses? Are they going to irritate it, or are they going to help protect the front surface, kind of like a bandage almost? And this is something that is of a great interest in our optometry and eye health community. And so what we did was we had some participants wearing contact lenses, and we left some lenses that were unworn. And then we also rubbed and rinsed some of the unworn contact lenses. So normally when you wear contacts, the way to keep them hygienic and clean, if it's a reusable lens, is that you rub and rinse it every night after wear. And so we're wondering if this standard technique is what people are doing when they're exposed to poor ambient air quality due to wildfire smoke. Is that cleaning the contact lenses, as we're probably presuming? And so what we found firstly was, we conducted scanning electron microscopy on all the lenses. And what we found looking at the surface was a deposition of different types and different shapes and sizes of particles on the lens surface. In this image here, you can see that some of the particles are embedding into the surface, while some are more just surface depositing. And then in the bottom one here with the orange label, when we rubbed and rinsed them, there is a reduction in the particle density, but still some of them are still there. And our overall density sort of aggregate results showed that in the green, in the smaller particle size, we've bracketed the size to 5 to 20 microns. There were a lot more particle deposition in the worn lenses than the unworn lenses, but didn't see that difference in the larger particle size. But most importantly, with the when we rubbed and rinsed, so now shown in orange, the larger particles, there's a significant decrease in those density, which means that rubbing and rinsing is probably removing those larger particles, but that change was not significant in the smaller size particles. So we're probably not dislodging those particles and they're staying on the lenses. So if a person keeps wearing them during the day, because this was only 15 minutes of exposure, it's unclear what happens. Do the particles leak into the tear film and then continue to irritate the ocular surface? Or does it just become a reservoir and just holds the lenses? So this was a very small pilot study, and there's definitely a lot more work to be done in this space in the coming years. Now, we also conducted a exposure study at prescribed burns with firefighters because we really wanted to understand what happens when you have longer hours of exposure versus the 15 minutes that we did in the fire lab at University of Tasmania. So we assessed firefighters' eyes before and after they went out to do about 5 to 7 hours of prescribed burning. And I can understand if anyone is logically thinking firefighters are wearing protective eyewear, so what's the point of assessing their eyes? So yes, in theory, that would be true, but a lot of our other work has shown that goggles, which are your sealing type, which prevent particles sort of entering into the eye space, they're not really well known. They're uncomfortable, they fog, they get sweaty in them. So most firefighters tend to prefer to wear sunglasses, and that was one of the findings of this study as well. About 45% of the time, firefighters were wearing sunglasses. About 25% of the time, they were wearing goggles, and remarkably, about 10% of the time, they were actually wearing nothing as well. But what we're interested in is what was happening to the eye surface, and what we see is once again an increase in a decrease in the comfort score. So 100 being very comfortable and 0 being incredibly uncomfortable. And again, in the bottom graph, 100 means very little to no dryness, and 0 meaning very, very dry. And there's a decrease in those scores. Once again, tear stability was reduced, and I would very much like to point out that firefighters in the before, with the exception of these 5 people, most of our firefighters had very, very good tear stability to begin with, which is probably why they're able to endure the smoke and work in that profession. But that certainly does decrease after exposure and after their working duties. And once again, they had quite healthy ocular surface, so the epithelial cell layer was quite intact, indicated by the 0 scores in the before, but some of them did have an increase afterwards as well. So quite similar to what we've seen with the fire lab results. So thinking about the mechanism of what's actually happening. So this image I've just taken from a review paper that we published a couple of years ago. It just summarizes the literature that was available on overall PM2.5 and not just wildfire smoke. So all the different causes. And so we see lots of changes happening to the eye surface. We have a loss of the microvilli at the top layer, which is really sort of the nutrient absorbing layer which keeps the cornea healthy. We have a change in cell shape. An increase in inflammatory cytokine, increase in dendritic cells, which are all sort of inflammatory mediators. So this is on the cornea, which is the clear middle part of the eye, and the conjunctiva, which is a white of the eye, and the red parts under our lids. Once again, we're seeing an increase in inflammatory mediators, changes to the cell shape, a lot more mast cells and eosinophils, suggesting of an allergic response, which I guess ties into the epidemiological literature that we have available. So I think there's little doubt that the air pollution does affect the eye surface and result in symptoms, but there's still a lot more that we don't know in this area. I would be remiss if I didn't talk a little bit about the back of the eye. So all of this that we've talked about has been the front surface of the eye. But there is epidemiological literature to suggest that smoke and particles are associated with glaucoma. So glaucoma, again, is not a common condition, but it is a condition which is, so once you have it for life. So there's a very strong burden with it. And there's a 14% increased risk of glaucoma with 10 micrograms meter cubed increase in PM2.5. But glaucoma traditionally in clinically, we worry about the eye pressure because we think high eye pressure contributes to glaucoma. But in studies, it's been shown that eye pressure and particular count is not actually related. But what is related is the ganglion cell layer, which is the innermost layer in the retina, which identifies what you're looking at, and it translates what you're looking at and the light and the colors. It translates all into signals and neurons that are then passed into the brain. So that layer is incredibly important, and it's not a layer that renews itself. So once you lose them, it is lost for life. So the PM2.5 exposure has been linked with the thinning of that really important layer in our retina. And then in terms of macular degeneration, that's the other major condition that's been associated with air pollution and the back of the eye disease. So macular degeneration is I think the leading cause of blindness in Australia. It is very, unfortunately, is quite common in elderly. It increases with age. Its prevalence, and there's a 19% increased risk, which is huge for a 10 microgram increase in PM2.5 exposure. Now, these are, again, I think that study is out of Canada. It's a longitudinal study. So how well it relates to here in terms of when we have episodic periods of bushfire smoke or like wood heater smoke. So it's difficult, there's limited literature available to draw associations with how that applies to Australian communities. But on a global perspective, this is quite alarming because macular degeneration, the treatment for that is quite burdensome. It involves injections in the eye and it can't always be cured. So that's why it is the leading cause of blindness in Australia. So these are quite strong associations with the posterior eye disease. So whereas the eye surface disease I talked about in the beginning was it can affect your vision in the short term, but we can help you recover from it as optometrists, whereas these conditions are a lot more dire and can have permanent impacts on the vision that are irreversible. So in summary, I think the work that we've done so far, we've been able to conclude that wildfire surface disease and public health guidelines, should state more strongly the risks that are associated to eye health, the symptoms that can be expected, and at the moment, the consensus-based advice that is available on managing this, because we don't have any clinical trials or data that directly answers questions like who should be using a steroid eye drop to manage their inflammatory eye disease, who should be using saline rinsing, who should be using over-the-counter lubricants. But we can give general advice that we have done in the past when like Black Summer happened. We still need a lot more literature and research in this area to understand what are the cumulative effects of exposure, starting off obviously with firefighters because they have that repeated exposure, and especially as their eyes aren't as well protected as we might have previously thought. We also don't understand who is most at risk of suffering from eye disease. From the eye surface disease, there is some epidemiological literature to suggest that those with respiratory disease are more likely to actually experience eye surface disease as well. So that's an interesting relationship worth exploring. And as I mentioned about the management as well. So we need some clear guidelines to understand how eye care professionals and pharmacists and GPs and hospitals and how they should be managing patients and what criteria determines how long you might need treatment for. And that's incredibly important if we unfortunately have a period like Black Summer again, where we had poor quality for 3 months. So you can't start someone on steroids and then keep them on them for months and months. That is not a situation that is good for their long-term eye health. So we need some guidelines and some more work in this space. And that's all I have to say. Thank you so much for listening.
Thank you so much, Suki, for that wonderful presentation, and really interested in the eye as a, I keep trying not to say this without having a pun around lens or looking through things, but it's a really interesting way of looking at the effects of air pollution, because you can get some really nice measures of the immediate response in situ, which I think is really difficult in other scenarios. So I think there's a lot to learn in this space. So thank you for sharing that. All right, so this session is now open for discussion and questions. We've had a very diverse range of talks in this particular session, some for diseases that might take a long time to develop, some for responses that might be more immediate. Does anyone have any questions for the speakers? There's one up there, and then you. Thank you. Please go. Yes.
Okay. Yeah, that was a really nice talk. Thank you very much. Just wondering, do you know what the relationship is between things like glaucoma and other eye diseases, and how they might impact on things like dementia and other brain diseases? You know, is it a kind of a drive forward from the eye into the brain that, you know, might be driven by air pollution and so on?
Yeah, I don't think it's as causative. I don't think there's a very strong relationship there. But we know that people who have dementia and Alzheimer's and that kind of cognitive loss, especially severe cognitive loss, they do have thinner retinal nerve fiber layer. But that might be more of a, I think it starts in the brain, the neuronal loss, and it eventually ends up coming to the eye. Whether that actually affects the eye and the vision and processing is not actually clear yet. Because the back of the eye is quite a closed system, so the way it, in my understanding, the way it can get exposed to air pollution and particles is through the systemic blood supply. So what happened? The front eye surface is exposed to the air pollution that's in ambient air. If our eyes are open, and whatever air we're in, that's what our eye is experiencing. But from there, it's unlikely that the back of the eye is getting exposed. But the back of the eye has a very, very strong blood supply in the retina and in the layers behind the retina. So what's happening in the systemically and with the inflammation, that's more likely to influence those back of the eye diseases. I hope somewhere in there was an answer to your question.
Yes, very much. Thank you.
Thank you.
Just a very quick follow-up on that. So you can measure cytokines in tears. How do you get those tears? That's really interesting.
Yes.
Yeah, there's actually several ways of doing it. And we actually learned that the way that we did it probably wasn't the most effective. So there's little glass capillary tubes, they're called, and they're very, very thin, and you place them right on the edge of your lid here. And if you just tilt your head down through a capillary action, it actually draws tears in. So if you know Megan, you can have a chat with her. We did it, and we used a lot of participants in the local Tasmanian community to do that. It's a very standard practice. And we collect about 10 microliters, and you can collect more as well. But we did find that immediate smoke exposure does dry the ocular surface, and it actually reduces the tear quantity. So with firefighters, we struggled quite a lot with collecting tears, but there are other ways of getting it. There's little strips that you can get that you can just put on your lid here, because just behind our eyelashes, there's like a little tear lake that's visible with a microscope, and you can put little special wetting strips there. And then you can extract tears out of that. So again, so 10 to 20 microliters is not difficult usually to get.
I was really interested in the immediacy of being able to measure that response too. It's very fascinating.
Thank you very much, John Ennis, EPA again. This whole workshop's been absolutely fantastic. It's just been a real eye-opener, pardon the pun. I didn't mean that. Everything I've heard is actually really worrying, in that sense that you think of all the other possible mechanisms. We tend to think of lungs and Tasmania and what have you. So really, really good, very worrying. The other thing I really like doing is talking to a room full of health people, is to say, from the monitoring perspective, having done it here for 17 years, we're not very good at it. We have our stations, but we select our stations in representative areas well away from the sources. We're delving into that a lot more, and we know that for wood heaters, wood burners for the New Zealand people, we are getting really high peaks from battery operated wood heaters sort of next door, like 10 metres away, like bushfire levels. When you think of those peak bushfire levels, we can be seeing those for the whole of the winter. Now, to my mind, they're the ones that are going to be presenting symptoms. When you do a aggregation across the whole of the area, study area, and you're using your one reference station and saying it's only 10 microgram per cubic metre this winter, you're not picking up the peaks. So I always like stirring the epidemiologists for that. But we're now starting to delve into that. I'd like to have a lot more data, and maybe next CASANZ I'll give a talk about it. But bear in mind that the peak levels in a wood heater environment can be really, really high, and they're probably where some of the medical conditions are coming from. Thank you.
Oh, thank you for holding that. Peter, I don't know if you're still online, you want to comment on that, seeing as you raised the wood heater and
Yeah.
your expertise in monitoring and things.
Well, not so much in monitoring, but John, it's a great comment. And as people know, in epidemiology, environmental occupational epidemiology, the biggest bane of our life is exposure assessment. You know, in fact, it's it is problematic. We measure exposure as estimates based on monitoring, as you say, John, or modelling. And modelling generally has reasonable spatial granularity. The temporal one, less so. And it is harder to get those peaks and to apply those peaks. And particularly, John, as you say, they're very localised. So I guess most people in the room there are, aware of things like land use regression models, and they, we try to get it down to a home address, but we aren't capturing those peaks either from residential wood heaters or other sort of sources. So yeah, taking on board, and John, if you turn up next year and you have much better ways of monitoring, they can lead to much better modelling, which can lead to better assessment and epidemiology. So I look forward to it.
We'll do our best. Thanks, Peter. The other thing, just to tag off on that, is we sometimes have, remarkably, even though we're the EPA, we have enormous difficulty getting traction sometimes to actually resolve wood heater complaints. Normally it's the councils. I'm not blaming them. We actually have ongoing, like, years and years of years trying to negotiate. It's actually the regulations just don't help in Australia anyway. New Zealand's sometimes way ahead of us. But all this information that I've heard today, if we can get that into the public domain, certainly in Tasmania, and say, look, I actually have anecdotally a case where a person has got this really weird neurological condition where her the stuff is actually getting into her organs, and we assume it's the wood smoke, but I'm not a medical person. So all that information that we can actually get in the domain and actually start to encourage community and the councils of how bad this really is, I think is to the better. So thank you very much, everybody.
Thank you. I think there are opportunities we can have to bring the policy people and the monitoring people and the health people together, the better. Maybe last question. Thank you.
Sure. Hey, Suki, this is a question comment for you. Look, thanks to all the speakers. It's been fabulous, as John so eloquently put. But Suki, the slide of the day, from my perspective, belongs to you, with that person in the orange suit sitting, exposing themselves to the exhausts from the oven. My question is, how did you get ethics approval on that one? And is that person okay? Because I'm not going to sleep until night until I know they are.
It's actually my supervisor, so they're definitely okay. So it actually got double ethics approval. So it got it at our University of New South Wales, as well as University of Tasmania, where we conducted the study. We got ethics approval because it's becoming common. Like, it's not that uncommon now. If you look at what's happening in the US and in Canada with their wildfires and the way the smoke spreads in those cities. So we basically said that what we're recreating is representative of what can happen in the community and has happened in the community. And so that day in, the first week of January 2020 in Canberra, when there was that so high, these people endured that for days, whereas we did it for 15 minutes. So, from that perspective, I don't think what we did was that high. I'm sorry I didn't have it on the graph, but if you look at what firefighters are exposed to in what they're doing every day, because we had them wearing as well, their peaks go up to well over 2,000. And and it goes up and down depending on the duties they're doing. And there's a lot of literature in that space as well about wildland firefighters and the duties they do and the exposure that they get to not only particulates, but also to gases as well. So although it's not something that I enjoy exposing people to, my family were in holidaying in Tasmania, and I made them participate as well because I needed participants for my PhD study. So so again, no, it's not something I enjoy, and it's not something that I hope I have to do for a very long time. But if it is happening, and so this is necessary.
With informed consent and all those sorts of things, of course, in place.
Absolutely. Absolutely.
Look, thank you so much, and a great question to finish it.
Whether you said ethics approval or idiots approval.
Yeah. Look, thank you so much. Can you join me in thanking all the speakers from the session today? It's been a wonderful. And on behalf of the Centre for Safe Air, I really want to thank CASANZ for supporting us to host this workshop. It's been really great to see, as I said before, having a range of people from different backgrounds in the room. You know, the more we can have these joined up conversations, the better outcomes we can achieve. So thank you for your participation and thank you for joining us today.